Hey everyone, and welcome to this explainer. Today, we're taking a true pharmacological deep dive into the clinical ladder of pain management. We are going to be using an escalating ladder framework to tackle this. Basically, we're climbing step by step, starting from mild discomfort all the way up to severe chronic pain. It's like a giant puzzle, and we're going to put every single piece together so you have a crystal clear understanding of these crucial concepts. Okay, let's dive into this. Here's our roadmap for today. We'll start with Section 1, opioid rules and characteristics. Then Section 2, mild to moderate pain. After that, Section 3 tackles severe pain and dosing, followed by Section 4, extended release protocols. And we'll wrap it all up with Section 5, adjuvant therapies. All right, let's kick things off with Section 1, opioid rules and characteristics. So, our absolute first foundational rule, and this is a big one, is that there is literally no ceiling effect for pure opioid agonists. Think about most over-the-counter drugs you take. Eventually, they just kind of hit a wall, right? Taking more doesn't help anymore. Well, pure opioid agonists aren't like that. Increasing the dosage continuously increases its effectiveness. So if a patient's pain gets worse, more drug equals more pain relief. But as you can probably guess, that escalating effectiveness comes with some heavy risks. And that brings us to characteristics 2 and 3. With chronic use, physical and psychological tolerance will invariably develop. It's basically a guarantee. And even more concerningly, overdose is a very real, very dangerous possibility. We have to constantly keep in mind that an overdose carries the potential for profound respiratory depression. The patient literally forgets to breathe. And with some of these specific medications, an overdose can even trigger seizures. Moving right along, let's step up to Section 2, mild to moderate pain. Let's break down the first rung of our clinical ladder. First up, we've got codeine and its congener pentazocine. For codeine, the usual adult dose sits right around 30 to 60 milligrams, and that's either given intramuscularly or orally, usually every 3 hours as needed. Now here's the catch. By themselves, these weak opioids are usually no more effective than plain old aspirin or Tylenol. Because of that, you're almost always going to see them prescribed in combination with those over-the-counter drugs just to boost their overall effectiveness. Now, I really need to pause here for a massive safety warning. You have to use codeine with extreme caution in nursing mothers. Why? Well, anywhere from 1 to 28% of women are what we call ultra-fast metabolizers of codeine. Their bodies just rapidly convert that codeine straight into incredibly high levels of morphine. And that resultant morphine, it can pass directly to the infant via breast milk, which can lead to a potentially fatal infant toxicity. It is absolutely crucial to remember that. Let's look at another unique medication for moderate pain, tramadol, which you might know as Ultram. This one is fascinating because it actually has a dual action mechanism. It's an oral opioid agonist, meaning it binds to your mu opioid receptors just like the others, but it also inhibits the reuptake of norepinephrine and serotonin. It's doing 2 jobs at once. Just remember, with tramadol, there's a strict ceiling. The maximum daily dose is capped at 400 milligrams. All right, stepping up the ladder again, here is Section 3, severe pain and equianalgesic dosing. Before we hit the absolute heaviest hitters for pure severe pain, we usually rely on combination pills. You'll see hydrocodone paired with acetaminophen all the time. That's what creates brand names like Vicodin. A standard Vicodin, for example, gives you 5 milligrams of hydrocodone mixed with 500 milligrams of acetaminophen. Oxycodone is also heavily used in combinations like Percocet. But here is the critical takeaway. There is a strict, non-negotiable ceiling on acetaminophen. You cannot, under any circumstances, exceed 4,000 milligrams of acetaminophen in a 24-hour period. If you do, you're looking at severe liver toxicity. So, ironically, it's often the Tylenol limit that dictates your maximum daily pill count, not the opioid. Okay, so how do we compare these much stronger drugs? We use equianalgesic dosing. Basically, to compare apples to apples, everything is referenced back to a standard baseline. And our gold standard baseline here is 10 milligrams of intramuscular morphine. So 10 mg of IM morphine is equal to 1.5 mg of IM hydromorphone, which is Dilaudid. It also equals 10 mg of IM methadone, but you've got to watch methadone closely. While its actual pain-relieving duration might only be 4 to 6 hours, it has a dangerously long half-life. If you just keep dosing it repeatedly, you'll get massive drug accumulation and severe central nervous system depression over just a few days. Because of that, mandatory dose reductions are totally essential if the patient stays on it. Now, let's pivot slightly to the mixed agonist-antagonists. These are also referenced back to that exact same 10 milligram IM morphine baseline. This group includes drugs like buprenorphine, which is a partial agonist, and pentazocine. But the one I really want you to focus on is nalbuphine. It's totally unique in this specific class because it has 0 sigma receptor occupation. And that little detail, it becomes incredibly important when we talk about side effects. So why does that sigma receptor thing matter? Well, there are two massive clinical warnings you need to know about these mixed agents. First off, if you give a mixed agonist-antagonist to a patient who is already physically dependent on pure opioid agonists, boom. You will instantly precipitate brutal withdrawal symptoms. You definitely don't want to do that. Second, remember how nalbuphine uniquely lacked sigma receptor occupation? Well, most of the other mixed agents do occupy those sigma receptors, and it turns out that specific occupation is exactly what causes severe hallucinations. Next up, Section 4, Extended Release Protocols. When we need continuous, around-the-clock pain management, we turn to extended release protocols. A prime example is OxyContin. This is a controlled-release formulation of oxycodone that lasts a full 12 hours. Because of that, it is absolutely not intended for as-needed or PRN use. If you have a patient who is already on short-acting narcotic combinations and you need to switch them to OxyContin, you don't just guess. We use a strict mathematical conversion protocol. For example, if someone is coming off a 24-hour IV patient-controlled analgesia pump, a PCA pump of morphine, you first calculate their total 24-hour morphine requirement and then apply a specific conversion factor to find their perfect daily OxyContin dose. Another huge player in the extended release world is the fentanyl transdermal patch, commonly known as Duragesic. You slap this patch onto the patient's upper torso and it continuously delivers pain relief for a massive 72 hours. It's incredibly potent. But here's the golden rule with fentanyl patches. You must never use this as a routine post-operative analgesic. Think about it. Post-op pain fluctuates wildly, and this drug is extremely potent and lasts for 3 days. The risk of triggering severe respiratory depression in an acute post-op scenario is simply way too high. Let's also talk about Avinza. This is a once-daily, extended-release oral formulation of morphine. It uses this really fascinating technology called a spherical oral drug absorption system. We call it SODAs for short. Essentially, the capsule is packed with numerous tiny 1-millimeter beads that slowly release the drug. Just like OxyContin, it's designed to be taken exactly once a day and should never be used on a PRN as-needed basis. But listen, that clever SODAs technology comes with a literal life-or-death warning. Avinza capsules must be swallowed whole. A patient can never chew, crush, or dissolve them. If they do, they instantly destroy that delicate extended release mechanism. And what happens then? The capsule dumps an entire 24 hours worth of morphine into their system all at once, which can easily be a fatal dose. Now, if your patient physically can't swallow the whole capsule, it's okay to open it and sprinkle those little beads onto some applesauce, but even then you have to strictly warn them, swallow the applesauce, do not chew those beads. Finally, we've reached Section 5, Adjuvant Therapies. So, what are adjuvants? Think of them as the helpers. They boost the effectiveness of the opioids so we can ideally use lower doses. Let's start with tryptophan. This is an amino acid and a direct precursor to serotonin. It requires pretty high doses to work and naturally has some hypnotic, sleep-inducing effects. But the key clinical detail you need to walk away with here is that chronic tryptophan therapy actually depletes the body's natural stores of vitamin B6. Because of that, you always have to prescribe a daily multivitamin right alongside it. Then we have antihistamines. You probably associate these with seasonal allergies, right? But they actually play a surprisingly big role in nociception, which is the way our bodies process pain signals. In pain management, they pull an amazing triple duty for our patients. They act as an anxiolytic to calm anxiety, they're an antiemetic to fend off nausea from the opioids, and they are mildly hypnotic to help the patient get some rest. A classic example we use all the time is hydroxyzine, or Vistarol, dosed up to 200 milligrams daily. We also rely a ton on anti-seizure medications and phenothiazines as helpers. Anti-seizure drugs, think gabapentin or pregabalin, are absolute game changers for targeting neuropathic, nerve-based pain. Phenothiazines, like flupenazine, are also great at reducing nociception. However, there is a catch you need to be aware of. Unlike the anti-seizure meds, phenothiazines actually carry the distinct risk of lowering the patient's seizure threshold, so you have to weigh that risk carefully. Wrapping up our adjuvants, we have corticosteroids and good old caffeine. Steroids are fantastic because they directly potentiate or boost narcotic analgesics. Plus, they increase the patient's appetite and can even reduce the toxic side effects of things like radiation or chemotherapy. And lastly, simple caffeine. Giving a small dose of just 65 to 200 milligrams can specifically supercharge the pain-relieving effect of acetaminophen, aspirin, or ibuprofen. It's a simple trick, but highly effective. Wow, okay, so we have climbed this entire pharmacological ladder today, step by step. We've covered a ton of ground, so I want to leave you with this provocative clinical question. Knowing that pure agonists have literally no ceiling effect, but keeping in mind the incredibly strict safety limits on combination drugs and the very specific effects of our adjuvants, how will you balance providing maximum pain relief while still ensuring ultimate patient safety? Mastering these tiny, vital details is exactly what separates a good clinician from a great one. Thank you so much for joining me for this explainer, and I really hope it helped clarify these complex concepts for you. See you next time.